Good morning. My name is Mariano Razon, a DNP student here at Maryville University. Today I will be presenting my DNP project entitled Examining the Effects of the TAPQ Screening Tool and NIH Self-Management Strategies on Increasing Compliance with Diagnostic Monitoring for Bipolar and Schizophrenic Patients, a pilot study. This project has the following committee members: Dr. Carla Larson, uh, a university professor, and she's the chair of this project. Dr. Maria Snell, my second reader, and Teresa Miquelins, the community member from Tri-County Community Mental Health Center in Bennettsville, South Carolina, where I am currently working. Background and significance of this project. Several studies have reported a high percentage of non-compliant behaviors among schizophrenia patients, ranging from 20 to 89%, and bipolar patients, ranging from 20 to 70%. This was conducted by multiple studies from Iwata to Vargas. In clinical practice, including community mental health centers where I'm currently working, this non-compliant behavior can translate to poor health outcomes and tragic stories. The purpose of this pilot research study was to demonstrate if self-management strategies and educational support intervention can significantly increase schizophrenia and bipolar patients' compliance to completing their scheduled diagnostic tests. The following are review of the literature I use in this project. The first one is from Iwata et al. From the Journal of Mental Health, study about insights of other predictors for physical exam for refusal of psychotic illness. In this study, the psychiatric patients who have an inadequate insight have been shown to be of a female gender, of a more extended history of illness, have a more severe significance, and were found to be non-compliant with the offered physical examination. Another literature I did include is about a study by Koopy et al. It's on information technology. Although the evidence is currently incomplete, the increased use of information and communication technology such as the SMS, short message service, email, and other electronic reminders has the potential to increase treatment compliance among people with mental disorder. Another little review is about treatment compliance and non-compliance of patients with psychosis by Rao et al. In this study, the psychiatric patient compliance and non-compliance to treatment are known to be multifaceted. According to the authors, to improve the patient health outcomes, healthcare providers must weigh many factors, including socioeconomic, such as age, sex, education, marital status, family relationship, and access to healthcare system, which they propose to have contributed to patients' compliance or non-compliance behavior. Another study is from Sanford and Rivers, where the TAPQ screening tool or the treatment adherent perception questionnaire was used. In this study, according to Dr. Sanford, treatment adherence perception questionnaires cover three areas. It studies the perceived behavior of the patient, perceived benefit, and perceived burden. It is a current and concise self-report valuable instrument for assessing patient perception and attitudes to their plan of care and treatment. The last one is by study by Vargas et al. About medication compliance. In this study, the author said personal beliefs and environmental elements highly influence the patient's ultimate decision to comply with treatment. Therefore, health providers need to discuss this concern with patients and their support system, their family, to improve compliance. Theoretical framework for this study. This study came out with the following PICO question. Do outpatients in community mental health centers who receive self-management strategies and educational support interventions compared to those who did not receive self-management strategies and educational support interventions continued with standard of care practices have increased compliance with scheduled diagnostic tests? With this given problem, I decided to use the McGill model of nursing to answer this PICO question for the following reason. The McGill model of nursing focuses on the family, health, collaboration, and learning. These are the fundamental concepts of the McGill model of nursing. Also, in the chosen pilot research setting, which is the Community Mental Health Center, schizophrenia and bipolar patients are managed and treated using the team-based treatment and family-centered approach to patient care. And this is being practiced in the site where I'm currently working. It is also known that improving patient compliance, which is the focus of this study, requires a change in behaviors knowledge and a change in behavior and knowledge through health education. Number 4, the patient support system, like the family and significant others, the healthcare providers, healthcare system, and other factors must also be considered as influential elements in improving patient compliance to treatment. Method and design for this project. This project used a 16 questionnaires from the TAPQ screening tool designed by Dr. Sanford. These questionnaires is used to determine the patient understanding of their disease. After they were able to answer these questionnaires, they were then provided with tailored self-management strategies and educational support interventions specific to their mental health diagnosis. And finally, I scheduled them for their diagnostic test. This TAPQ screening tour covers 3 major areas: patient's perceived behavior, perceived benefit, and perceived burden. The sample for this population group was studied using frequency, relative percentage, and cumulative relative percentage. Focus was on age, gender, and education. Also marital status, ethnicity, employment, and living condition. All these factors are considered to be influential in the patient's compliance to behavior. So the summary for this statistics show that the mode for distributions with my sample ages are 58 to 60 are 15.4%. There are 12 patients in this study, 6 patients diagnosed with schizophrenia, 6 patients diagnosed with bipolar, but 10 of them are female. 6 of them have an education of high school, 9 are single, and there are 7 African American. Most of them are unemployed, 11 of them, and 8 of them are living with their family or significant others. The median age for my population group is 45 years old. And the mean are within 33% for age 45, 50% completed high school education, 75 are single, and 58% are African American, and 66% live with others. More data analysis, more sociodemographic records of the participants. As you can see, we have the age group, the gender, the education, and the breakdown. Based on the data collected, I'm using the quasi-experimental studies algorithm. I've chosen to use the post-test only design compared with norms for these pilot research studies. This statistical test design requires no pretest to the research subject and does not require a control group. This statistical test design assesses the effectiveness of an intervention fashioned to provide a positive range of value compared to the average population value. The following are the results of the intervention and the test. Perceived behavior, perceived benefit have to be defined with perceived burden. Perceived behavior is the impression that the participant will pursue the recommended treatment plan. After completing the 16-item TAPQ screening tool with a 12 subject, 33% consider this perceived benefit, and then 0.50% have the burden, and for the perceived benefit, 0.45. With perceived behavior, 33% of the participants acknowledge that they would pursue the recommended diagnostic test because they find this test useful to their medical condition. While perceived behavior with perceived burden, 50% of the participants will not continue with this test because they consider this test burdensome. On the other hand, with perceived benefit, 45% of the participants believe completing their diagnostic test a burden and undesirable. However, when the test was completed with their diagnosis test, it shows that 66.6% of the research subjects did complete the scheduled diagnosis test, although they exceeded the 1-month time frame, while 34% were not compliant. Overall, I can say attaining more than 50% diagnostic test compliance is an encouraging positive result for this population group despite various research limitations. The following are the research limitations I have encountered during this project. First, a small sample size due to COVID-19 restrictions, which threaten the external validity of the project, followed by participants' lack of understanding of the questionnaires and the careless self-reports, which threatens the construct validity. Also, there's only one clinical setting which threatens the internal validity of the study. There is no design randomization in this study, so therefore it threatens the internal validity. There are also potential biases of the novel researchers, such as inconsistent rating of the subject responses and answer to the research questions, secondary to inadequate technique, preconceptions, and fatigue. Also, possible errors in data collection and analysis. Further, the use of weak and insufficient statistical analysis techniques. There's also the issue of time restriction to thoroughly conduct the research study and do follow-ups of these subjects. There was no power analysis conducted in this study. Although 45 to 50% of the research subjects declared in their TAPQ screening tool that completing the diagnostic test to be burdensome and undesirable, 66% of them completed the scheduled diagnostic test after being provided with self-management strategies and educational support intervention. I believe attaining more than 50% diagnostic test compliance is a moderate but an encouraging positive result for this population group despite various research limitations. It is important to note that healthcare providers' awareness of the patient's perception of the disease is crucial in planning and delivering distinct self-management strategies and educational support interventions to improve compliance to diagnostic tests and other treatments. A change in patients' behavior through health education and removal of barriers can translate to better health outcomes and tragic stories. Implication for practice. The data for this pilot research study can be used to guide my practice in the design and use of pilots in the pilot use of the intervention, such as the self-management strategies and support intervention to enhance patients' compliance to diagnostic tests and other clinical treatment. As a healthcare provider, understanding patient perception of the disease will facilitate the appropriate and effective use of specific self-management strategies and educational support intervention to improve patients' compliance to treatment. Although it is an essential task and an arduous responsibility to modify patients' health-related behavior, most healthcare stakeholders believe that a well-informed healthcare consumer are more responsive and compliant to their health and well-being. This is according to Nickman and Kovner. Conclusion. This pilot research study aims to explore in a community mental health center if self-management strategies and educational support intervention can enhance the compliance of schizophrenia and bipolar patients with their diagnostic test. If given enough time, I can effectively manage this research limitation. I hope to explore and find solutions to other contributing factors to patient non-compliant behaviors and recommend support for elements sustaining for these compliant behaviors. I believe it will lead to a higher rate of patient compliance with their diagnostic tests. Also, given the opportunity, I would like to expand this study in other community mental health centers to enhance the research internal external validity. Because pilot studies are feasibility studies, I hope to inspire other researchers to continue the work in helping this population group improve their health outcomes. The DNP program here at Maryville University has made me realize the importance of higher education and gave me the preparation and confidence to be an agent of change in delivering health services to our diverse population group with challenging health conditions. Also, with this education, I learned not to accept the given status quo and be open to possibilities that anything can improve in healthcare given the proper commitment, teamwork, and having a noble value of service and care for others. Hopefully, this DNP project will continue to inspire me with my further studies to conduct research to improve the health outcomes of the patients. As an agent of change in a fractured healthcare system, expensive healthcare system, I hope that this DNP project can improve the health trajectories and outcomes of this population group that are vulnerable in our society. With the support of the administration in the workplace, I hope that I can present this outcome and have them be inspired to improve the processes, the services, and the operations in the clinic, in the 3 clinics where I'm currently working, and further improve the care and services we deliver to this vulnerable population group. Uh, the, the experience in creating this DNP project is very meaningful to me. As I finish the study, I have learned that It is important for advanced practice nurses to continue further studies to improve the healthcare system in our country. Thank you for your attention, and the following are my references, and I am ready for your question if you have, and thank you for your attention and input. Have a good day.